Kia ora. Welcome to this. It's the last of our videos for the diabetes series for HSC 6310. So these hyperglycemic emergencies stem from an inadequate supply or an inadequate response to insulin. You may recall that the pancreas manufactures and releases insulin in response to rising blood glucose levels. The effect of insulin is to increase the cellular uptake of glucose, or in other words, it's transferring the glucose from the bloodstream to the cell interior for storage. Thus, the effect of insulin is to lower blood glucose. In normal circumstances, the homeostatic loop for this is completed as the blood glucose falls, and this signals a reduction in insulin release. So, the issue with diabetes mellitus is going to be an inadequate supply or an inadequate cellular response to insulin. And the net effect of this is going to be an increasing blood glucose level. This increase in BGL has both short-term and long-term complications. Now, this presentation is going to focus on the former, that is, the short-term acute presentations that we see with hyperglycemia. As the amount of blood glucose rises, so does the concentration or the osmolarity of the plasma. In other words, the increased amount of glucose will attract fluid from the interstitial space into the blood. In the short term, this leads to interstitial dehydration. Essentially, the fluid's left to dilute the bloodstream. The cardinal symptom is thirst and the desire to drink more fluid. If this remains uncorrected, it's going to cause dry mucous membranes and it's going to amplify skin tenting. But at the end of the day, we've got interstitial dehydration. If untreated, the glucose-laden plasma entering the kidney is going to saturate the normal glucose scavenging mechanisms. Now, once these mechanisms are overwhelmed, the glucose is going to enter the filtrate, and this too is going to become more concentrated. If you check in your A&P books, it's probably going to describe the filtrate as hyperosmolar, that is, having a higher concentration than normal. Now, the problem with this increased concentration is going to attract and hold greater amounts of fluid in the filtrate, and hence it's going to form a far greater volume of urine. So the filtrate that would normally return to the plasma is now going to end up in the bladder, and if this remains uncorrected, it's going to lower the plasma volume and you're going to get hypovolemic shock. In this slide, this is represented by this overlapping blue and yellow area on the Venn diagram. So this is the first of our short-term problems, and it's called hyperosmolar non-ketotic shock. Sometimes we refer to this as HONK. Now, this is life-threatening if not reversed. The second of our problems is going to be metabolic acidosis. The problem here is that the cells are going to require an alternative to glucose to be able to produce energy. One solution is that the liver converts stored fats into glucose molecules. This is not a particularly efficient process, and a byproduct is the production of ketone bodies that are going to enter the bloodstream. Now, these ketones are a hydrogen-donating compound. In other words, they're an acid. Because they're not a volatile acid, the excess hydrogen is going to remain in the body, creating an acidotic state. And it's going to disrupt the cellular environment, and it's going to affect every body system. This condition is known as diabetic ketoacidosis. Now, it's more prevalent in type 1 diabetics because they have a complete absence of endogenous insulin. And it's the insulin that prevents the conversion of the fatty triglycerides into the ketone bodies. On the other side of the coin, it's less likely to occur in type 2 diabetes, as quite often there is sufficient endogenous insulin to prevent the ketone formation, but there's not enough to control the blood glucose, so you still end up with HONK. In particular, the central nervous system is sensitive to these acidic changes. And so we're going to see alterations in mentation, eventually an alteration in the level of consciousness, and it can finally lead to seizures and death. The excess acid in the system also causes a very deep and rapid respiratory pattern. It's a type of hyperventilation called Kussmail's respiration. The hyperventilation is going to leach carbon dioxide and produce a respiratory alkalosis. The excess ketone bodies can also produce a sweet, fruity odor on the breath. The acidity is going to cause the peripheral blood vessels to dilate, and this can potentiate any shock that's created by the honk. Uncorrected diabetic ketoacidosis is going to result in death. The acidosis will produce an untenable cellular environment, and the shock will result in organ failure, thrombotic events in the microcirculation, which is going to end up presenting as disseminated intravascular coagulation and multiple organ failure. Both honk and DKA can exist at the same time, and particularly for the type 1 diabetic who is more susceptible to the ketoacidosis, this can produce a very complex picture and a patient who can become ill in a matter of hours as opposed to days. So to review the information so far, hyperglycemia causes a hyperosmolar shock state and/or a metabolic acidosis. The more common reasons for this is going to be an underdosage of insulin or another anti-glycemic medication. So this might occur when someone has failed to administer their normal insulin, or if perhaps on an insulin pump for some reason the pump has failed. So recognizing the hyperosmolar state relies on the following. First, there's going to be an elevated blood glucose level, and typically this is going to be well over 20 millimoles per litre. We're going to recognise the initial interstitial dehydration through thirst, poor skin turgor, and dry mucous membranes. Recognition of the shock is going to be typically through a tachycardia and hypotension, and there's going to be increased urine output. Recognising the ketonic state relies on identifying the type 1 diabetics for which DKA is more likely as an outcome, as there's no endogenous insulin that's going to suppress this from happening. The results of the acidosis is going to produce Kussmail's respirations, a fruity odour on the breath, and if we have the ability to measure them, we're going to see elevated ketones in the blood. Again, the more marked changes are going to involve the central nervous system. We need to be aware that either or both of these conditions can follow uncorrected hyperglycemia, and that both can be life-threatening. The management goals of hyperglycemic emergencies are first to ensure that the ABCs are controlled. The next is going to be the short-term therapy, which is to use IV fluids for combating shock and acidosis and protecting the microcirculation and the renal function from microthrombotic events. However, we must always keep in our mind that this is a rearguard action and should do nothing to prevent the primary goal of getting the patient to definitive care where insulin or other antiglycemic therapy can be initiated. The emergency administration of insulin poses secondary dangers, and it can result in severe changes in potassium levels, for instance. For this reason, potassium levels are tested and supplementary potassium infusions are often administered simultaneously with insulin. It becomes a delicate balancing act and it's not suited where point-of-care testing is unavailable. So at this point in time, we don't do this in the back of an ambulance, but we can protect the circulation and guard against shock with the use of IV fluids. So the management strategy in the back of the ambulance is to provide fluid therapy and expedite transport to definitive care. So this brings us to the conclusion of our review of hyperglycemia. Hyperglycemic emergencies are characterized by high blood glucose and occur in either undiagnosed or diagnosed diabetics, but it's going to be related to some form of underdose. The symptoms that we see with hyperglycemia are related to one or both of the short-term problems that we're going to see. And the first of these is shock. So this is the one that was secondary to the excess glucose creating hyperosmolar plasma, causing interstitial dehydration, and then hyperosmolar urine, which is going to deplete the blood volume. This is the one that's characterized by low blood pressure and a tachycardia despite higher urine output than one might expect to find. The second problem is the body having to scavenge energy from ketone bodies. The byproduct is a metabolic acidosis. Now, this can potentiate the shock caused by the other problem, but even without the shock state, the acidosis is going to affect cellular function and result in severe symptoms if it's uncorrected. Pre-hospital management. This is going to focus on getting the patient to definitive care where insulin and fluid control can be undertaken while controlling for potassium imbalances. The short-term pre-hospital treatment provides fluid resuscitation for the shock state and protects the microcirculation and renal function from microembolism and the effects of acidosis. Now, these therapies are effective but must be undertaken in a way that does not delay transport to definitive care. I hope this has all been useful. If you've got any questions, feel free to get hold of us. In the meantime, ka kite.